ما في أحد يزهمون من رائد، ما في أحد من الأورجرايد كوميتي يزهمون من فوق؟ من الأورجرايد كوميتي بالشباب الصغار يعني، أنت عجوز زينا واحد شباب صغير. الساعة 6 أنا أوكي شوف قصدك لحظة بس قصدك قبل البريك يعني بعد أو تو سيشن من أوكي قبل البريك خليك Then move forward, guys. Our resident. Can you move forward, please?
Oh, we have to pick some other. You have to be more positive, you know, give rewards rather than punishment. So I'm going to get started with this. So the cases are based on actual patients, and then I spin off in some of their clinical scenarios, and there will be some touch points with questions about management options. And what we best do is we'll ask somebody to discuss the options, and then I'll go forward. There's no right or wrong. There's almost never a black and white, right or wrong in these kinds of things, as you know. And so there is no reward or punishment either. Let me say, when I set up the cases, I focus a little bit also on the symptom severity and the bother. And one point I want to make is that the symptom score, as you know, has these 7 questions. And when you add them up, there's 3 questions that have to do with storage symptoms. So maximally you can have 15 points, right? That's kind of important. And there's 4 questions that have to do with voiding or obstructive symptoms, and you can have 20 points. So, and I'm making this point because the questions are set up like that. And the graphs on the questions here, the graphs kind of show the numbers in the text. So this is a 65-year-old patient, and he scores 19 points, so he would be considered just above moderate, severely symptomatic. And 10 of those are voiding, and 9 of those are storage symptoms. So the green is the total possible you can gather, and the red is what they have. So it's sort of a balanced thing. And they say, quality of life question, that they're mostly dissatisfied with the way it is. On my finger examination for 30-gram prostate, a negative urinalysis, and his flow rate is a 330 cc, voided volume is, and the peak flow rate is 12.7. The residual urine is 45. And so I show this down here, just out of interest. So you'll see here the voided volume. This is the residual, and this is the total capacity. So the voiding efficiency is 88%. This is just a graphic representation of the numbers on the left-hand side. And the PSA fits in at 1.4. Good. So this is the basic data. So the question is very simple. Let's just say this patient comes to you and he says he's mostly dissatisfied with the sort of situation in which he finds himself. What would be a normal first treatment? There's no right or wrong here, really. And if somebody wants to just go through, what do people normally do? What do you normally do? I asked one of the residents if there is one.
Is there a resident here? Okay, yeah.
That's good, yeah. And are there anything available here, such as over-the-counter, we call them, or nutraceuticals or herbs or so?
Yes.
Is that available in Saudi
Yes,
Arabia?
There are.
And is it
Many
widely
preparations.
used?
Yes.
And patients come in already on them?
Some, yeah.
Some,
Yeah. And what is sort of the belief? The belief is it's they take it, but we discard it, or we...
over the counter.
Yeah. Mm. So you think it should be just an alpha blocker monotherapy, and why would that be? So you think it's a classic example for an alpha blocker monotherapy. Okay, we're going to stay with you for a little bit on this case.
Can I ask you, Dr. Orban?
Yeah.
Do you make it a point to ask about patients' erectile function at the baseline?
Yeah, I do make a point. I didn't put it here, but later on this plays also a role. Yeah, the SHIM score. I get actually, because an electronic health record makes it easy, you know, I have the patients fill it out, and so I have an IPSS and a SHIM score on just about every patient I see, actually, so that I have a basic idea about that. So yes, I agree with that. So this is a typical patient. Why? Because he has moderate to severe symptoms, and the symptoms are balanced as storage and voiding symptoms, and he has an acceptable voiding efficiency. The voiding efficiency is 88%, and vis-a-vis my talk on the residual urine, can I ask you, do you have a problem when the residual urine is higher, and when do you have a problem?
Actually, the thought is actually how much is high in modern stomach. He's living more than 150, especially that high possibility.
But what is the consequence of it? Let's say he had 150, would you not give an alpha blocker then? What would you? And what if he had a residual urine of 200? What would you do then?
I will still do the same. I'll give him alpha blockers, follow him up,
But now it's 300.
with follow-up.
Well, you repeat it twice. At 300 cc's a residual urine, and he voids only 150, so his voiding efficiency is not so great.
After starting therapy.
Then you
After
do-
starting alpha blockers,
No, when he first comes.
it wouldn't affect my management at the beginning.
So your management is not affected by residual urine any level as long as he can urinate, even if it's the voiding efficiency is less than 50%.
Exactly.
Okay, so that's not common. I mean, around the world you find people who say, no, you got to do a surgery, it's dangerous, and they don't know why it's dangerous. Nobody knows really, is it dangerous? They say infections and stones, but as you know, that's pretty rare, so we feel it's pretty acceptable. The patient has a low PSA, there's no need to worry about cancer, and his risk for progression should be low. The small prostate, the PSA is 1.4, and there's almost no risk for progression. So let's just say the same patient, but now if you look at the same patient here, he now has more storage symptoms, and other than that, it's pretty much the same patient. He just is more frequency, more urgency, and more nocturia. I'm sure you'll have the same problem that I do, that this is very common that the patients present with more storage symptoms, and they're more bothered by the nocturia and so forth. So let's just say this patient really is more in the category of OAB. What would you do then? Again, I'll show you this here. So the same numbers. He urinates well, minimal residual, PSA still 1.4, small prostate, 65-year-old, and adequate sexual function is not an issue. So what is common here? Do you say, whoa, wow, I don't know about this, fill out this frequently volume chart? Do you do invasive urodynamics? Do you feel a cystoscopy is a good idea? Or do you still go with an alpha blocker?
Actually, as a baseline, I will still give alpha blockers and follow him up. If his symptoms improves, which happens most of the time with those patients. If you relieve their obstruction, their storage symptoms improve with time. So I wouldn't go with other investigations as a baseline. I'll just start alpha blockers.
So is it common here to give alpha blocker like an option E, to give alpha blocker together with antimuscarinics? Is that a common thing?
Yes, but maybe not at the baseline. First, I will start with alpha blockers. Next visit, if he's not improving, his PVR is minimal, I will give him antimuscarinic with it.
So one of the points that could be made here that studies such as the TIMES study that was published some years ago now in JAMA, there was the first study, was a parallel group study for tamsulosin plus tolterodine versus tolterodine, tamsulosin alone versus placebo, showed that the immediate initiation of combination therapy was very good for these kinds of patients. And then, of course, Astellas did studies with solifenacin and tamsulosin called the Saturn study and the Neptune study. And they were very highly published with long-term extension. And I think that in Europe, they received an approval for tamsulosin solifenacin. So I frequently start patients on simultaneous alpha blocker and antimuscarinics if they present with that. And it's based on those studies. Let's just say 3 months pass, and let's just say we do all this, and his total symptom score changes, and also his storage symptoms change, but he still has ongoing nagging nocturia. And so he scores 4 points, and you'll ask him, what does that mean? Do you really get up 4 times at night? And he says, yep, 4 times, and that's a bother, I don't feel rested, etc. What would be your next step then?
And he's currently on antimuscarinics. He's currently on antimuscarinic therapy.
So he is, let's just say he's on tolterodine or vesicare or any one of those, Tovias or fesoterodine or any of those.
I will ask for a voiding chart for him, ask him about his voiding habits.
So you could get various things, get a frequency volume chart, do invasive urodynamics and whatnot. What about changing the antimuscarinics? Is that a popular thing that you do?
It is. It is.
So I made the question up, but I forgot to add the option of a beta-3 adrenergic. Is mirabegron an option here?
Not yet.
Yeah. So many docs now resort to that. They switch, because it doesn't give you a dry mouth and constipation. It has a problem with the blood pressure, but it's an alternative to the anticholinergics, and so that's one additional possibility. Well, the switching of anticholinergics in the United States, the recommendation is really not based on efficacy so much, but based on age comorbidities. As you know, some of them are quaternary ammonium salts, and they do or do not penetrate the blood-brain barrier, and many of them are associated with dementia and failing mental acuity. So, for example, ditropan or oxybutynin is recommended against in the elderly, and many of the other ones are. So trospium sanctura works actually a little bit better in the elderly. So I use the anticholinergics more based on their side effects and their risk profile, while the efficacy is fairly the same, I would say. But if the patient is driven by like this dry mouth problem or gets constipated, that's a good idea to go to the mirabegron. It's usually more expensive, but it doesn't have that at all, And of course, then there is a combination of those as well. So you wanted this voiding study, and so this is what he does. He basically urinates in a fairly normal range, I would say. They recommend to drink 60 ounces a day, and so he urinates this much. His nocturia episodes are actually 3 to 6, and it's about 700 to 950. So that basically is sort of 1/3, so vis-a-vis the definition of nocturnal polyuria. But so when you ask him now specifically, so he says that he eats fairly late, or 8 or 9 p.m., and he has some beers and he watches TV and all that kind of stuff. And he says that he always keeps water next to him, and so he keeps drinking at night. So we give him some lifestyle advice to reduce this fluid intake and do all these. And the patient improves, and he does another voiding diary, and the nocturnal polyuria improves, but the patient still has nocturia episodes 3 to 5. What would be now your next step? So it's a 65-year-old patient. It's a modest-sized prostate. PSA is 1.5. We dealt for a while now with his storage symptoms, and we got 2 voiding diaries, and he is left, despite lifestyle adjustments, with nocturia. What would he be doing now?
I will go ahead with cystoscopy since he has unresolved storage symptoms on medical therapy and behavioral therapy, just to rule out any bladder pathology.
And why don't you discuss the other points, A through E, just what you think about those options? It's not something you commonly would do. And what about giving a diuretic in the morning?
For an cardiac patient who doesn't need diuretics.
Yeah, it has been done, you know. People have done that, actually. They gave a diuretic in the morning to quote-unquote dry him out a little bit, you know, so that there would be not... It's this idea of the hidden, non-clinical, you know, heart failure with storage of fluid in the tissues and excretion of the urine at night. Has been done. Studies have been published. I don't do it, you know, I'm just saying it here. Any other treatment, medical treatment, switching on drugs, you wouldn't do that. You would do a cystoscopy, okay? Yeah. So we may get to the cystoscopy aspect of it. I couldn't really bring for it. I think that progressively more so when I see patients and frustrated with my medical interventions and it doesn't lead me to the desired result, I also resort to imaging studies, as I explained, whether it's an ultrasound or whether it's a cystoscopy. But I do want to bring our attention to a publication. It's just, I believe it's just 2 or 3 months old, and the European Association released guidelines on the medical treatment of nocturia in men with LUTs based on a systematic review, and they released these guidelines. And so when you look at the studies that have been done with desmopressin, now I do not know if this is widely available or used. It's a tricky business because you have to set the patient up to check his sodium in regular intervals, because a certain number of men will have substantial decrease in their sodium. But there's these studies here that are listed there, and if you look at the mean difference against placebo, these are only the placebo-controlled trials, you can see a reduction on nocturnal voiding frequency, and it's about the number 1 comes to mind against placebo. You may recall that I gave you the Cochrane analysis, right? The Cochrane analysis that was presented this year at the AUA on desmopressin. It found that desmopressin reduced nighttime urination episodes by 1.5, and the placebo effect was 0.8. So the delta was 0.7. So this is a mean difference in the European guidelines. It's about 1 full episode against placebo. This is better than any medications, combination medical therapy, etc., and so it's worthwhile to consider. The meta-analysis also looked at hours of undisturbed sleep, and if you look here, there is a substantial increase in the minutes of undisturbed sleep. These are minutes on the y-axis of this analysis. So it is something that I resort to not infrequently when patients are getting frustrated, and if they are willing to come to the lab and do their assessment for sodium, I'll be willing to go down that route, that particular route.
A couple of questions, please. Would the age of the patient influence your decision on whether or not to try desmopressin for them? And then the other question would be, would you assess him for things like pitting edema, and would you refer him to a sleep specialist?
Yeah, I just assume right now that that he doesn't have pitting edema and clear-cut evidence for congestive heart failure. Then I would basically try to look at his medication profile, obviously, and work with his cardiologist, because there are things that could be improved. Sleep studies is a big topic, and we have a sleep center at our university. I'm sure you probably have something similar here. Texas is considered one of the states with a high obesity problem, so we have a lot of patients that have truncal obesity. They also have a lot of sleep apnea that goes along with it. So I'm fairly convinced that a large number of my patients have obstructive sleep apnea, and they get aroused. And when you ask patients, you know, the advisors always ask the patient, do you wake up with the urge to urinate, or do you wake up and then you urinate because you're awake? And I don't think the patients have a clue in the world, you know. They don't even know what you're asking, in my opinion. So it's hard to make sense of what they tell me. But I do get sleep studies, and I probably get sleep studies on 10-15% of my patients. And obviously many of them end up with a CPAP, and they reduce their total wake episodes at night. Many of them do. Good point, though I didn't, it's, you know, these things are all pretty convoluted, so I didn't go into great detail with that. Yeah, you know, I don't like to give it too much in the very elderly, but I'm not sure that the sodium issue is a problem restricted to the elderly. Maybe I'm missing something there. But I gave it, you know, in patients in their 70s. I would not be so happy giving it in the octogenarians. Yeah.
This is your first sleep study, so it was certain BMI to do
Sleep studies? No. I think I would order a sleep study when this is a dominant problem for the patient, the nocturia or the nocturnal polyuria. When I did my frequency volume chart, and I got that idea from the frequency volume chart, and then I look at the patient. But you know that it's not just truncal obesity and BMI. It's also the neck. You know, you can tell by the patients who sort of have a very thick neck or just sort of an obliterated neck, they are far more likely to have obstructive sleep apnea. So I get a gestalt on the patient, and I would not say I have a hard cutoff for BMI, body weight, or anything of that sort.
It might help also to simply ask the question of the patient if he or she snores, or if he suddenly wakes up at night to show that.
Or better yet, ask his wife. So this, you know, that would be certainly a very good idea. So let's go and move to another case. And yeah, that's great. Thank you so much for doing that. So this is now a patient who scores a little higher. He scores 25 points, balanced more now towards the obstructive voiding symptoms, and he's unhappy about it. We think his prostate is about 60 grams. And he has a little bit less of a voiding efficiency, 74%. His residual is 90. His capacity is 340. His PSA is 2.8. So it's a 65-year-old patient, PSA 2.8. We think it's a 60-gram prostate, and he's severely symptomatic. What would be your next step? And you can also add other things to it, obviously.
I would still start him with the medical therapy, either with alpha blocker alone, or also consider the combination therapy.
And what about the PSA of 2.8? Is that considered in a 65-year-old patient acceptable?
I would follow it up, and we'll see the trend. But I'm not going to go ahead with the biopsy right away. So I would start him either with monotherapy with alpha blocker, or also consider the combination given his PSA and prostate one.
Good. So he was given this combination of, he was given Hytrin because of insurance reasons and finasteride for 6 months, and he had very little improvement. So he says, that didn't really do much for me 6 months later. I'm still having the same problem with hesitancy, straining, and plus all the other symptoms. So what would you think at this point would be reasonable of these options or other options?
Probably an imaging study at this time is beneficial, especially looking for medium low, which is usually not responding to medical therapy.
Do you think for efficacy reasons it would be a good idea to double up the tirazosin?
It's not a bad idea, but if he had some improvement, I would double the dose. If there is very little improvement, he's not benefiting from the medical therapy, then I would consider the imaging study.
So most people would think that tirazosin 5 milligrams and doxazosin 4 milligrams would be a little underdosed, and one might go higher, but I agree it's not going to be the end-all, be-all. What about finasteride, dutasteride efficacy switch?
I don't think there is much difference between them. So.
Okay, good. And okay, that sounds good. And so in this case, the patient actually had a pressure flow study done, and the pressure flow study shows this. It shows a PDT at Qmax of 75 with a flow rate of 7.5, and so his bladder outlet obstruction index is 75 based on the flow rate. At 75 minus 15 is 60, and his residual urine on this study is 110.
So he clearly has a high pressure volume, even though he's on medication. So at this point, I would consider going for surgical intervention.
A surgical intervention.
Yes.
Yeah. So this is 6 months into the treatment, so we assume that an alpha blocker changes the BOI or the PDT at Qmax a little bit, 5, 8 or so. The 6 months of finasteride changes it a little bit, but it's still the Abrams-Griffiths number is still 60, the BOI, and over 50 is obstructed, so he's still obstructed. So you would say, enough of that, you need a surgery? You already suggested you want to do an imaging study.
Yes. But at this point, after the UTS, I think the surgical intervention is the best option for me.
There's nothing wrong with
I would obtain an imaging study before going for TRP.
Yeah, there's nothing wrong with the way I put the urodynamic study in front, because a urodynamic study is advisable if your first best choice of treatment, the combination medical therapy, was ineffective, then it's indicated. And secondly, if you think about a surgery, then a urodynamic study is recommended per guideline, not mandatory, but recommended. So there's nothing wrong with getting that. But so that's what you are doing now. Instead, this patient is switched to silodosin, has a little bit of improvement. This goes on for a while, but he's still not satisfied. And now, he, in addition to everything else, he has an endoscopy with retrograde flexing of the flexible cystoscope. So how would you interpret the scenario? Now keep in mind he's now 18 months on some form of treatment.
Yeah, so he has a medial lobe or intrazygote lobe, which usually does not respond to medical therapy. So at this point, I would counsel the patient to go for surgical intervention, preparing the TRP or...
Do you think that this tissue here doesn't have any alpha-1A receptors or has no 5-reductase type 2?
I'm not sure about the receptor subtypes.
Yeah, it's interesting that if you analyze this tissue separately and you do a TURP just on the middle lobe and you do it on the lateral lobes, it's indistinguishable. It's stromoglandular hyperplasia one way or the other. There's smooth muscle in there, there's glandular tissue, and there's clearly type 2 5-reductase in there. But despite of that, you're practically speaking correct. Middle lobes don't respond. They are a common source of medication failures. So it's correct, even though histologically we're not sure why. Yes, sir?
So the PSA was 3.8 or 2.8?
2.8.
2. So you don't consider antibiotics, Ceprofay or something like this for 6 weeks?
Well, he's now 18 months on medical management for BPH. The symptoms were mostly voiding, obstructive, not storage, A, and B, I'm not a friend of antibiotics to manipulate the PSA. I think, the data there are quite weak to suggest that they play a role in that. And in the absence of a bacterial infection, I'm not a friend of giving antibiotics for any period of time, 2, 4, 6 weeks, in hopes of affecting either a PSA change or a symptom status change. I think the point is interesting to make, though, that the tissue is the same, but the response to medical therapy is not the same. So that patient would be a candidate for a TURP, in my opinion, or a laser ablation. Personally, I prefer, this was one of the questions that was asked, I prefer to do a TUR in these cases simply because I can put the loop behind the middle lobe and resect it, and with a green light laser, it will shine down on the trigone. It's a 70 down angle, and I don't like it as much, so I prefer to do that. The button TURP, you sit on it, and you possibly get down on the trigone. So none of that really works for me just as well as a TURP would be. So let's just say another scenario, the same patient now, okay, so he's 18 months on this treatment, and we do the flexible cystoscopy, but now it looks like this. There's no intravesical lobe, just the lateral lobe. PSA was 2.8, there's about a 50, 60 gram prostate. Now he's 18 months on the treatment. He's not happy with his obstructive voiding symptoms, but no intravesical lobe. What would you say is an option for him?
Since the patient is still unhappy, I would consider doing surgery for him.
And what kind of surgery would you now recommend for him?
Laser ablation.
A laser ablation, yeah. So the point here is if you don't, we just talked about it and I was asked what I do, and I do either a laser ablation or a TURP, but we'll just talk in the break a little bit about it. This is also a good candidate for the Urolift procedure, for example. I just learned a large number of patients here are very concerned about ejaculatory function. So maybe the patient already had a problem because he's now 18 months on finasteride, and he would love to get off it to sort of recover that. And the Urolift procedure is good in a sense that it maintains ejaculatory function. Let's change the scenario for you around a little bit. And let's just say the pressure flow study comes out very differently, the same patient. So now the PDT at Qmax is 45 centimeter water, the flow rate is the same, but now your Abrams-Griffiths number is 30, the residual urine is 190. So how do you interpret this? Is this an obstructive pattern or?
No, it's not an obstructive, but he has a very high post-void residual.
Yeah, so he has a high post-void residual. He has a fairly low pressure during voiding. And the flexible cystoscopy is done and it shows this type of appearance of the bladder. How would you characterize that in your description?
This is very primitive bladder.
Yeah. So it's interesting. So as long as I practice urology, we always do a cystoscopy and we saw tuberculation, heavy tuberculation. And it's interesting that despite us doing cystoscopy for 100 years, we don't have a sort of a categories, you know. I wish there would be internationally recognized categories to go from tuberculation to cellules to diverticular to indicate the worsening. This I would characterize as pretty bad because he has throughout tuberculation, he has cellules and he has diverticular formation. So how would that change it now with that very low detusor pressure, okay, the number is 30, and a high residual, and modest prostate, 50 grams, maybe smaller now. He's 18 months on finasteride. What would you tell him? He is clearly a detusor is not working well.
I'll tell him that even if we can proceed with surgery, he will still have symptoms. They will not be much improved.
Mm. So, and this brings us to this unresolved issue that is the fact that about 20% of our population, when they come to seek treatment or seek surgery, they have undiagnosed detusor underactivity, and this is the prevalence of detusor underactivity in relevant studies that have been done, and you can see it ranges from a low of just under 10%, 9%, to a high of 40% in selected men, but on average it's about 20%. And I do want to say that there is not any good medical therapy. Bethanechol is still used, but you know it doesn't really work anything. So you advise the patient, which one of these things would you advise him?
I would advise him to teach him for self-catheterization.
Or you would not advise him for a surgery?
No.
Okay. You just said a TURP. You would do a TURP, though, a moment ago.
No, for the other patient. For this one,
yeah, but this is a patient now who you diagnose after frustrating 18 months of treatment with detusor underactivity by urodynamics. So you say there's not a good treatment, you have to do self-cath, or you'll do a TURP anyways, or you do self-catheterization.
I could go for TURP and then to see whether he improves or not.
This is I find this around the world is the same thing. You'll get this, there is objective responses and then there is subjective gut reactions to this problem. I think that urologists worldwide, they say, well, if a patient is known to have detusor underactivity, he's known to have a poor chance of resuming normal urination, so I advise self-catheterization. And you ask the same urologist in a coffee break, what do you really do? Most of them say, no, I really do a TURP and hope for the best. So this is like this total disconnect between what people say in a public setting and what they do privately. I come back to this paper I discussed from the AUA, not because it's a gigantic series or because it's a big number of patients, but it's some people who honestly looked at the question and they treated patients with detusor underactivity and they showed a fairly good response. Very small number of patients, to be sure. It was just like some 30 patients or so. But I fall into that camp that I tell the patients, look, what I'll do is I'll do a resection, I'll do a laser, and I place a suprapubic tube, and I put a plug in the suprapubic tube, and then I want you to urinate and record your residuals and keep it on a sheet to see how you improve your voiding efficiency. This is actually, I didn't annotate it with the name and the date, but this is actually an abstract we submitted, I think from last year, and it's based on patients where I did that. It was 42 patients. I did a TERP, and they all had a suprapubic tube, and 82% of them succeeded and had the SP tube removed because they succeeded in urinating with a decent voiding efficiency of 60-70% or more. But it took them 1 month. 1 month. So what we also found was that patients who had certain characteristics did not do as well. When they had an indwelling catheter, they failed more often than if they were on intermittent catheterization or not yet on catheter dependence, and so depends on the scenario. But overall, I think a 75% rate of success can be expected. So I'm not personally giving up on the TUSO underactivity. I actually offer a surgery with an SP tube, and I tell the patient that this is basically the idea behind that is that I want them to use the SP tube as a training tool. Well, when they fail, let's just say this goes on for 6 weeks or 8 weeks, and I say, look, then I say to them, either we're going to leave the SP tube in, and you will get infected, and we'll treat you when needed, but you get infected, and we change it ever so often. And you can either hook it up to a bag, or you can drain it intermittently, or we take the SP tube out and you self-cath, but those are the only options left at this point. So it's not a loss, really. I already have the SP tube, and some people choose that. It's maybe the less good option, but some of these patients, we realize they are octogenarians. For them, self-catheterizations is a lot easier said than done. In America, many of these patients are in nursing homes, and I would not say that all nursing homes have the facilities to do self-catheterization or a nurse catheterization on these patients 4 or 5 times a day. It's difficult.
Doctor, is there a way to sub-classify them into 2 groups, like low-risk group and high-risk group of failing voiding based on objective things, like urodynamics?
Yeah.
So we can tell the patient you're high risk to unbenefit from this procedure, or you have a likelihood of benefiting based on, for example, a very low voiding pressure.
Yeah. Okay, so I didn't have, in the 42 patients, I didn't do that. I didn't have enough patients to really break down in categories. But may I just say, I feel the urologic community should do a multi-center trial enrolling patients with diagnosed TUSO underactivity in multiple centers into treatments, and hundreds of them, and do a perfect TURP or a good TURP, place a suprapubic tube, and see about recoverability. And once you do 300, 400, 500 in multiple centers around the world, you probably can learn when it works if you multivariate analyze it, how long they were in retention before, what their retention volume was, what the size of the prostate was, what the appearance of their bladder was by cystoscopy vis-a-vis tuberculation. It's a perfect object. If there would be a young academic urologist interested in voiding dysfunction, he would just need to call up some of his buddies and set up a multi-center trial. I brought this up as an unresolved issue. This is a topic that is patient-based clinical research. It's perfect because we really don't know, and my little 42 patient series will not answer that question either.
Routine cystoscopy for those patients who fail voiding after therapy, just to check that the optimal section was done.
Oh, well, I would have to say yes, I do. Because urologist do a follow-up cysto and say, oh, buddy, you forgot you had a bladder neck contracture, you had this, you had that, This is embarrassing. So I think I do, yeah. Because if a patient then goes to another doctor somewhere else sometime later and he finds out he has a little, let's say you induced a urethral stricture, or he has a fossa navicularis stricture from the instrumentation, or he has a bladder neck contracture. That's embarrassing, and I don't like to particularly to be embarrassed, so I would do a follow-up cysto, a flex cysto. I think
Just one question, please. would you fix a suprapubic tube for all patients, even if they were voiding before the TRP?
I sometimes do, and I do it if their voiding efficiency is poor. Let's say they have a voiding efficiency of 20–30%, they urinate 100, but they retain 300–400, then I say to them, you are as good as in retention, you know, really. I mean, as close to that as possible. So I put the tube in, and then you keep the log. To keep a log of voided versus residual urine is good for several reasons. A, the patient has something to do. He takes care of his own, he helps in his own care. B, it's an amazing feedback that the patient sees, wow, the numbers change. I do better, you know, over time. And C, it's perfect for me because he faxes a sheet to me, or some patients, they take a cell phone image of their diary and send it to my cell phone. And so I say, okay, you're making progress, you know. So yeah, that's what I'll do.
Any burning questions before we proceed to the next part? Okay.
Thank you very much. My question is about the experience about using bifenthral.
Yeah.
Not bifenthral.
Yeah.
As a medical treatment for underactive atrocious. Because I think it's not has been used thoroughly. I think it needs further evaluation. Because I have some patients that have been trying this medication for quite some time. The results are still there are some patients getting better.
Well, I wouldn't say the studies are brilliant, but as you know, there is probably a dozen studies that were done, some placebo-controlled, others not, but they are sometimes shocking. And when I go back to 7:30 this morning, when I said what makes a good paper when you read the literature, most of those would not pass muster. There are some studies with 20 patients, you know, and dubious enrollment criteria. I doubt that any of the studies really meet power and sample size calculation. So I have a slide with a long list of those studies, but they all are bad studies. So I would not go out on a limb and saying it is implausible, impossible, it does not work. Maybe it's worse than effort in some patients. I think the database is weak, and again, maybe it is still a necessity to do a randomized multi-center trial where you say, okay, here's the outcome. I think I'm not going to do any more cases, but let me just get back to the early morning session. So here is how this would work, right? We would say our outcome is resumption of normal voiding defined as a voiding efficiency of at least 60 or 75%. That's the outcome. So we think the placebo-treated patients, they will achieve that in no more than 10% of cases, and bifenthral should achieve it in what percent? What would be a good result? 20%, 30%, 40%? How many? So you think that's clinically meaningful? You got a deal. I mean, if you say it's clinically meaningful if a third of all patients respond favorably, then we set up a trial to show that bifenthral improves it to 30%, placebo in 10%. That's a 20% absolute difference, and we probably need only 80 patients in each arm to show that. So it just takes 4 or 5 centers and interested urologists to put together a trial and do it. It can be done. It's an answerable question if you set it up correctly. And I'm glad to visit this issue because it harks back right there to early this morning when we talked about good projects, answerable questions, and questions that are of importance to us in urology. Yes?
Do you routinely do urodynamics for patients who fail medical treatment?
Who fail medical treatment?
And the second question, what's your opinion on angioembolization of prostate for patients and cohort of patients with non-mechanical disease?
So I do not do routine urodynamics for every patient who fails. I don't do urodynamics before medical therapy, but if I give it my best shot and the patient is an abject failure, I will first probably do an imaging study in most patients before I do a urodynamic study. But if I go with a patient, I say, look, you didn't do well, and I do a cysto, and I don't see a middle lobe, I don't know what's going on, it's just a big prostate, then I say, well, we can do a surgery, and then I would do a urodynamic study.
So you will evaluate the bladder with your next cysto prior to therapy?
I would be okay if I do an ultrasound. Earlier in the morning, I explained that I do my own little experiment with a handheld ultrasound that sort of walks with me in my clinic from room to room. And I do far more ultrasounds of the prostate than I ever done before. And I do it because I know the importance of size and shape of the prostate in allocating patients to the correct treatment. I learned that in my life in urology, the importance of that. Okay, so we talked about in the break. I'm not a big fan of it. I haven't seen any good results with it in my own patients, and I realize that there are some centers that publish, you know, and I probably do some injustice, but when I say that, and please forgive me, this is a weird scenario where there are 2 centers in the world that publish 80% of the data, right? It's kind of a strange thing. And it's usually presented by radiologists, and when you ask them a question, they can't answer it. And so my own experience is fairly bad, and so I haven't really embraced it as a treatment alternative that I would offer or even discuss with my patients, honestly. So, you know, I want to remind us that AMS tried to pursue an FDA indication for ethanol injection in the prostate, and they abandoned any and all plans immediately. One day after an unfortunate urologist in the UK injected the liquid ethanol in the bladder dissolved, the patient had a big hole in his bladder, and he ended up with a urinary diversion. You may not know this, but this is a fact. AMS did a randomized study with liquid ethanol injection in the UK, and the study was immediately abandoned. Why? Because in BPH is a quality of life disease. You cannot go to sleep and wake up with a urinary diversion. That's just not possible. So they stopped it. Well, I noticed that in Brazil, they had done partial cystectomies for bladder detrusor necrosis after angioembolization. But it's not an FDA trial, so they keep happily going on. I think these are side effects that are unacceptable in a quality of life disease. So the long and the short of it is I haven't seen the quality of data and the magnitude of data from a variety of sources around the world that would lead me to believe that this is a good treatment.
Very last question from Dr. Raj. Very last question.
There's a common practice here where the patient who fails trial way, they double the dose of tamsulosin. So what do you think of that? The other one is before they go for open and simple prostatectomy, they give a dose of Casodex, like a month of Casodex. So what do you think of that?
They give the dose of Casodex because of bleeding.
Just to shrink the prostate.
Yeah, but the studies show very clearly that 1 month is not enough. First of all, I doubt actually there is a single evidence-based study that shows what Casodex actually induces in shrinkage. It's all basically analogy. You think finasteride and dutasteride shrinks by 25 to 30%, ADT shrinks by 40% maybe, so Casodex must shrink by what? 30%? It's all supposition, there's no data. Secondly, there's no study that says that the shrinkage is really affected at 1 month. So I don't know. I thought it had to do with blood flow issues or bleeding issues for the slice diminishment. And then comes another question. If I do a simple enucleation of the prostate, your prostates here must be something else, because I don't care if it's 150 or 180 grams. Do you really care? No. So I don't. If I say to a patient, this prostate is too big, forget it, I'm going to do an enucleation on it, that's it. Then I do the enucleation. And I don't care to shrink it 25%. I can understand the idea of shrinking it prior to brachytherapy or so, you know, but not there. What was the first question? Tamsulosin? Yeah. Well, you know, you just have to read the phase 3 trials they did for the FDA, and you realize that between the 0.4 and the 0.8 dosing, that there was a IPS symptom score difference on aggregate in the group of only, you know, 1 point or so. It was very minimal. However, just a second, that doesn't mean that there are not patients where this is a good strategy. And it could be a good strategy under certain conditions. For example, This was never really analyzed this way, but if you have patients who respond somewhat but not fully, it is possible that double dose will work better. Again, the aggregate data show only between 0.4 and 0.8 a 1 point difference. But if you were to study poor responders to 0.4 and add them to 0.8, there might be a greater response. So I do it, many people do it. Some estimates say it's 10 to 20% of patients who are on 0.8. Cost twice as much because there's no 0.8 milligram tablet. Yes, sir, absolutely. So we'll abandon the question, and I see that, that Dr. Nera is here, so we're secure for the afternoon session. And so my last presentation for the morning session will be on medical management. And so I am a little bit behind now, so I have maybe 15 minutes or so. Yeah, good, yeah, good. So fortunately, or unfortunately, the field of medical management, there is not that much new. All the drug classes are established and we know what we're doing more or less. So I just draw your attention to some new insight that came out of the last few years. I want to again emphasize the fact that we're treating not the hyperplasia by and large, but we're treating the symptoms in the presence of enlargement, in the presence of obstruction, and we don't care of the bulk of the patient who have histological hyperplasia. I believe still that the EAU, the AUA, and the SIU guidelines from 2012, where this algorithm is straight taken from, is the best guideline because it gives you this idea of treating men, medically speaking, in 4 broad categories. Small glands with low PSA with an alpha blocker, the larger glands with combination therapy, adding antimuscarinics for those with storage symptoms, and PDE5 inhibitors being a plus in those with comorbid ED. So of all the alpha blockers that are available in the United States, in Europe, or in Japan, naftopidil, I don't believe there is an efficacy difference, but because of the substantial difference in selectivity for silodosin, which is 168 selective, and tamsulosin, which is 10-fold selective, versus these, which are not selective on the receptor level, there's a difference in side effect profile. The side effect profile was investigated in a meta-analysis by Curtis Nickel, and I like to draw from this paper. This shows also the difference between the alpha blocker and placebo in terms of symptom score and flow rate, and there really isn't that much of a difference between the drugs, again suggesting that for efficacy reasons there's no need to change between the alpha blockers, flow rate or symptom score. But there is a fair amount of adverse events, and these are the vascular-related adverse events for alfusis and tamsulosin, teirazocin and doxazin, and the GITS formulation that are actually directly attributable to vascular-related events and have a p-value of less than 0.05. Now notice please that tamsulosin does not have any of those side effects, but if in orange you show where the p-value is between 0.05 and 0.1, even tamsulosin has a higher odds ratio for almost all of the vascular-related adverse events. The big divider is, of course, the ejaculatory abnormalities, and since this is a sensitive issue around your patients here in Saudi Arabia, I would say it's always important to note that patients will just not tolerate silodosin much because the rate of anejaculation is 28% in the studies, and in some patients' population it may be 50% or higher. It does suggest a greater efficacy. This has been shown. I don't have the time to discuss it, but there is a little bit better efficacy, but the side effect is clearly noticeable and twice as common as with tamsulosin. The drawback of the alpha blockers